Bismillahirrahmanirrahim. Dysmenorrhea is actually painful menstrual period. So it's either a primary or secondary cause. Okay. So painful menstrual period is known as dysmenorrhea. So and primary is also known as spasmodic, and it's usually start in 2 year of menarche. So and yeah, it's associated with the puberty, not associated with any pelvic disease. So it's decrease after the childbirth or with the time. So mostly it decrease with the childbirth or with passage of time. But the secondary is known as congestive. It's usually pre and post menstrual, and there is always pelvic disease. So it's a secondary to a pelvic disease, okay, or any pathology, and it's gradual onset, mean as the time pass, so the severity of pain is going to increase. So in this case, by the time this severity is going to decrease. Okay, so it's menstrual which occur in the menarche. It's associated with the pelvic disease. Okay, what is the underlying mechanism of this pain is actually progesterone. There is a release of progesterone in the at the time of menstruation. So there is high level of progesterone which stimulate the prostaglandin. Okay, so this prostaglandin actually do what? It increase the myometrial contraction. As the myometrial contraction increase, so it may lead to ischemia, reduce the blood flow to the uterine, okay, uterus. So as the uterine activity is increasing, but there is low blood flow, this lead to some pain sensation. So there is pain sensation due to ischemia or sensitization of nerve terminal toward the prostaglandin. Okay, so ischemia and the prostaglandin sensitivity lead to pain. Okay. So the same mechanism here. So decreased blood flow cause pain, or the sensitivity toward the prostaglandin, which cause a myometrial contraction, and it lead to pain. Okay. So we have two types of primary or secondary cause. Okay, primary is usually the pain is midline. Okay, it's in the midline, while the secondary is not a midline pain. So this is a common feature you will see, and there are other some comparative point. For example, onset, their presentation difference, associated symptom, pelvic examination, etiology, and management. Let's see. So in the onset, it's usually occur within the 2 year of menarche, and it's prior or at the menses and lasts for 48 to 72 hours. Okay, while in this case secondary, it's occur in 20 to 30 year of age and may extend pre or post menstrually. Okay, and they are associated with pelvic disease. In the presentation, there is a main complaint is cramping in the lower abdomen and radiating to lower back thigh. Okay, cramping in the lower abdomen and then it radiate to the back. Okay, while in this case there is dull and itching. So these are often the associated symptom in the primary is the nausea, vomiting, diarrhea, fatigue, and headache. Nausea, vomiting, diarrhea, fatigue, headache. This in the primary. While you do not see these associated symptom in the secondary. Okay, what do you see? You see the dyspareunia, mean painful urination, infertility, abnormal bleeding. So these are other associated symptom can occur, but you do not see the nausea, vomiting, diarrhea in the secondary cause. And when you look at pelvic, in the primary, pelvic examination is normal, while in the secondary you will see the finding of underlying pathology. Okay, so it's depend upon the cause. So in the etiology, as I mentioned, prostaglandin increase myometrial contraction and decrease uterine blood flow. Okay, ischemia, and in this case you will see the underlying cause. For example, endometriosis, the pelvic inflammatory disease, adenomyosis, leiomyoma, pelvic congestion syndrome, ovarian cyst, cervical stenosis. So these are most common cause of the secondary dysmenorrhea. Okay, so how you manage this case? So start as the problem is prostaglandin, so give the NSAID. Okay, and then oral contraceptive and progesterone. So initially we give this if the pain become chronic, mean long term pain, it's not controlling after these drugs, so then we go for neurectomy. Otherwise we limit it toward the NSAID and the oral contraceptive and progestin. In this case, first you treat the symptomatic treatment, mean you give this trial, and then and also treat the underlying cause. So this is a major difference in the second primary and the secondary. Okay. And treatment, as I mentioned, so you in the medical you give NSAID, so the mefenamic acid 20 to 500 mg 8 hourly. So these are different NSAID options you can give. Okay, if the medical treatment is failed, then we go for surgery. It's only in chronic condition. Okay, if it's a chronic pain and it's not treating with the medication, then go for surgery. Surgery where we target the nerve, uterine nerve or the pre-sacral nerve plex. Okay, so here in laparoscopic approach, okay, so where we target the uterine nerve, and in the LPSN, mean pre-sacral nerve plex, where we target the superior hypogastric nerve plex. Okay, and in the hormonal, you know better, we give the oral contraceptive, oral pill contraceptive, and the progesterone, and there is other the intrauterine tube. We give them in this way. Okay, this is LNG-IUS, where we give levonorgestrel releasing intrauterine. So this is placed here, so it's prevent from pregnancy. Okay, so it's again a contraceptive type. And in the secondary dysmenorrhea, as I mentioned, we give you trial of the NSAID, contraceptive, and progestin, and also treat the underlying cause. Okay, here is the schematic approach. Okay, so trial of NSAID, look for the symptom, and if it's not it, so go for the check out the STD, and then the pelvic examination, and rule out the different etiology. Okay, so and treat those etiologies. Okay, so this is same mechanism. So it's so same thing which we explained in the last slide. Okay, thank you very much. This is all about the dysmenorrhea.